Today, we're diving into a condition that is, without a doubt, a true clinical nightmare: streptococcal toxic shock syndrome. And look, this isn't just some bad infection. This is a physiological firestorm that can completely overwhelm a patient in just a matter of hours. So, understanding this isn't just for exams. It's about being ready to act when the clock is ticking faster than you can believe. Let's get right into it.
So picture this. A patient shows up, they've got a fever, they seem a little confused. You're thinking through all the possibilities. But here's the terrifying part. While only about half of these patients are hypotensive when they first arrive, almost all of them will be in deep, profound shock within 4 hours. This is not a slow decline. It's like falling off a cliff. That incredible speed, that's the signature of this disease.
So what in the world is this thing? Well, the official definition really tells the whole story. The words you got to lock onto are abrupt, vascular collapse, and multi-organ failure. And it's all driven by toxins that the bacteria are pumping out. It's better to think of it less like a simple infection and more like a full-blown chemical attack on the entire body that leads to a total system meltdown.
Okay, so if we want to have any chance of fighting this, we can't just throw treatments at the symptoms. We have to understand what's actually happening under the hood. So let's zoom in from the bedside right down to the cellular level and really look at the why. Why does everything collapse so fast? This is where we uncover the bacteria's devastating game plan.
And here is the absolute crux of the whole thing. The reason TSS is so catastrophic isn't just because of the bacteria themselves. It's because of the weapons they deploy, these things called superantigens. These nasty little molecules hijack our own immune system and turn it against us, making it the main driver of the destruction. So how does this superantigen weapon actually work? Well, let's walk through it. Normally, our immune response is super precise, right? A specific invader gets processed, and it might activate, say, 0.01% of our T cells. But the superantigen, it just cheats. Step 1, it completely bypasses that normal, careful process. Then, in step 2, it acts like a master key, just forcing a connection between our immune cells. And the result, in step 3, is an absolute disaster. Instead of that tiny targeted response, it indiscriminately activates 20 to 30% of our entire T-cell army, all at once. This leads to step 4, the infamous cytokine storm, a massive, uncontrolled flood of inflammatory signals that makes our blood vessels leaky, our blood pressure crash, and our organs fail.
But wait, it gets worse. The bacteria have a second weapon in their arsenal, something called M protein. As you can see here, the bacteria actually shed pieces of this protein right into the bloodstream. These M protein fragments then grab onto a blood clotting factor called fibrinogen. This new complex they form directly flips on our neutrophils, which then start dumping out even more inflammatory chemicals. They are literally pouring gasoline on the cytokine fire that's already burning out of control.
All right, so we've seen the firestorm that's happening on the inside. So how do we actually spot the smoke from the outside? This next part is all about diagnosis. It's about seeing the clues that this internal chaos is creating before it's just too late.
One of the most classic signs you might see is this rash. Now, it doesn't always show up, but when it does, it's a huge clue. Clinically, it's called a generalized macular erythema, but really, it just looks and feels like a bad sunburn that's all over the body. If you see this in a patient who is getting sick, fast, well, streptococcal TSS needs to shoot to the very top of your list.
And this right here, this is such a critical point. The infection has to get in somehow, right? But the entry point can be ridiculously small. We're talking about a tiny little cut, a scrape, maybe even just an infected hair follicle. This is exactly why you have to do a meticulous head-to-toe skin exam on these patients. You've got to find the source.
So beyond the physical signs, there's actually an official checklist for diagnosis. It really boils down to two main things. First, hypotension. That's the crashing blood pressure from all those leaky blood vessels we talked about. And second, you need evidence that multiple organs are failing, at least 2 from this list. And it all makes sense, right? The kidneys fail because they're not getting enough blood. You get coagulopathy and liver problems from the massive inflammation. The lungs fill with fluid, causing ARDS. It all points back to that same underlying chaos.
Now, here's a quick but important distinction you'll see: the difference between a confirmed and a probable case. It's actually really simple. If you meet all those clinical criteria and you find the group A strep bacteria somewhere it absolutely should not be, like in the blood or spinal fluid, that's a confirmed case.
But if you meet the criteria and you find the bacteria somewhere it could just be hanging out, like the throat, we call it a probable case. It's a key difference for tracking and reporting.
Okay, we know what it is, we know why it happens, and we know how to spot it. Now for the most important part. How do we fight back? This is all about intervention, and believe me, every single minute counts.
Look, in those first few chaotic moments, you're not going to have a perfect diagnosis. So the single most important thing to do is to treat this like any other case of septic shock. You pull out the sepsis playbook and you run it hard. That means massive amounts of IV fluids, vasopressors to keep the blood pressure up, starting broad-spectrum antibiotics immediately, and urgently hunting for the source of the infection. So once you get that lab confirmation that it's group A strep, you can zero in with your antibiotics. And the standard of care is this critical 1-2 punch. You hit them with high-dose penicillin to kill the bacteria, and you hit them with clindamycin to shut down their toxin production. Using both of these is absolutely non-negotiable, and you're about to see why.
So that brings up a really great question, right? We all know group A strep is usually very sensitive to penicillin, so why bother adding the second drug? Why not just use penicillin?
And the reason is actually pretty brilliant. Penicillin, yes, it kills the bacteria. But there's a weird catch. It can actually be less effective when there's a huge number of bacteria. More importantly, killing the bacteria doesn't stop the toxins that have already been made or are still being made. That's where clindamycin is the hero. It's a protein synthesis inhibitor. So think of it this way. Penicillin is taking out the soldiers. Clindamycin is blowing up the weapons factory. You absolutely have to do both to stop the assault.
Okay, so we've covered the what, the why, and the how. Let's wrap things up by looking at the hard reality of outcomes and boil all of this down to the most important things you need to remember. I'm not going to sugarcoat this. Even with everything we can do in a modern ICU, the prognosis for this disease is just terrifying. The mortality rate can be as high as 56%. Just let that sink in for a second. That's worse than a coin flip. That number is why every single second of early recognition and treatment matters so much.
So what actually makes a difference in who survives? Well, this data gives us some clues. On the left, things like older age and, interestingly, NSAID use are linked with worse outcomes. But look over on the right. This is the proof in the pudding for our treatment plan. Treatment with clindamycin is strongly associated with lower mortality. The evidence for IVIG is a bit more mixed, but clindamycin is a proven lifesaver here.
And that brings us to the final, and maybe the most important question of all. With a disease this fast and this deadly, what is the single most critical action any of us can take? It's not some fancy new technology. It's not some rare drug. It is simply suspicion. It's having STSS on your radar in the first place when you see a patient who is circling the drain. That early recognition, that suspicion, that's the one thing that can change everything.